Joining me now is Dr. Mitchell Maiman, Chairman of Obstetrics and Gynecology at Staten Island University Hospital. Welcome.
Thank you for having me.
Thank you. I really want to talk to you about what happens with these medical mysteries. And when a patient comes into the emergency room and we really don't have a clear understanding of what's going on, what's our first approach that you think is the most effective in really making the right diagnosis?
Well, I think the most important thing is to talk to the patient. The patient has the answers. History is the most important thing in solving these mysteries. And usually 75% of the time, the final diagnosis can be made just by the patient's history alone. But too often, we avoid that today and we go right to fancy diagnostic tests.
You have to talk to the patient.
The patient has the answers. Talk to her again, re-interview her. Find out the intricacies of her symptoms, and that will almost always lead the way to which avenue you should take.
When we're in medical school, we learn how to question patients and how to go through that history. And I think as time goes on, especially with the technology we have and the testing we have, we lose that a little bit.
I think we've lost that a lot, Suzanne, over the years. I mean, when I was a student, it was all history. And now the diagnostic tests and the MRIs and the fancy things are so powerful, and they give you so much information that too often we jump right towards those things. But they just give us data. They don't put it all together for us. I still think it takes a human brain to do that.
I'm so glad we have a use now for the human brain. But the medical mystery is really about that collaborative effort of putting the story together. I know that one thing that patients can complain about when they go into the hospital is that they get questioned by so many different layers of people, especially in the academic university hospitals. The intern, the resident, the fellow, the attending. What do you say about this to the patients?
Well, first of all, when they have these complex problems, a lot of times multiple consults are called. And unfortunately today in medicine, every consult and every consultant sees their own little world.
They're focused on their one organ, right?
Right. And that's good because the doctors are so good today in their subspecialties. But on the other hand, they don't know that much about other subspecialties. So multiple doctors have come into the scene. The patient is repeating themselves over and over again, and tests are ordered. And you need a captain of the ship. You need like a house kind of person to put it all together and make it one unifying hypothesis.
I think that it's important that we do say this multidisciplinary approach, though. The team coming together and giving their opinion about that one organ system or that one issue is critical, but really it's about figuring out how each one of these little pieces is part of the bigger puzzle.
I agree. And the doctors have to listen to each other. Sometimes when I get called in, I want to hear each consultant's experience. I want to know what their expertise is, all right, and help me to understand their world. And then you have to put all the worlds together. And at the end of the day, somebody has to make a final decision about which way to proceed.
But I agree with you. I think one of the things that I appreciate more than anything is when a doctor calls me and we get to talk about our respective fields and tie the story together and figure out, well, where are you coming from? Because this is where I'm coming from. And putting the story and the picture of what each of us has to say respectively makes it a more fulfilling conversation, really.
Well, you mentioned something very important, physician-to-physician communication, also becoming a bit of a lost art. It used to be all physician-to-physician, and now we tend to speak through EMRs and house staff and things like that, and there's nothing as important of talking directly to the doctors who know the most.
Not by computer, by telephone, and not by text.
Well, maybe old style, but that's my opinion.
No, I'm with you.
And the other thing you mentioned, which is so important, Suzanne, is residents and students and so many different house staff involved in the case. And sometimes patients, say, why do I have to be seen by a student or a resident? In my world, students and residents make everything better. They force academics, they force you to think. They ask questions, and you have to give good answers based on scientific data. So I think it makes everybody better, and if I were in a hospital, I'd want to be in a hospital that has residents and students.
I think it brings us to a higher level. It forces us to think. It forces us to be more academic. And especially in the situation with these medical mysteries, you want to be thinking. You want to be thinking outside of the box and about all the possibilities.
Right. I believe in these medical histories, one has to be like Sherlock Holmes.
Right.
I mean, there are clues, and you have to go find them. You have to look under every corner, and you have to look everywhere to find out one extra fact, one extra diagnostic test, one thing that's a little bit off. And you can't take anything for granted. Anything that is slightly abnormal has some meaning. And I think that's the key to getting it right.
Everything has meaning. Everything has meaning, and you just have to put it together. But you know, I think about the patient who comes in, who has all of these symptoms that might be very odd and they cannot be connected. What do you tell the patient? What do you tell the family when the diagnosis isn't so clear?
Well, I think you have to be honest with the patient. You know, the patients look at the doctors as, godlike, and they're going to come up with the answer quickly. And you have to explain to the patient and the family that this may take some time. This is not an everyday occurrence what the patient has, and it's going to take some time, it's going to take some patience to figure things out. And I think when you do that in advance, I think the patient's families are very supportive of that.
And how do you deal with the patient? The patient who's probably scared, frustrated.
Right.
What do you say to the patient?
Direct, honest communication. If she's frustrated, I'm frustrated too. If she's a little scared, then I'm scared for her, because I want to find out what's wrong with her. So there's nothing to replace just being honest with the patient, telling her where you're at, come off the pedestal, come off your high horse, and have her become part of the process with you.
I think it's important to remind us all that those of us who went into medicine really went in with the desire to heal, to figure it out, to treat, and in having that discussion with the patient and having that discussion between doctors, we're all on the same page. We all want the same outcome.
I would like to think that doctors are still like that. I would like to think that doctors still go into medicine for those reasons. I think in today's day and age, sometimes that tends to get lost. There are so many distractions, and how we have to chart everything. And sometimes I'll see a patient in a room, and she'll tell me she's been there for 2 days, and no doctor has talked to her in the last 2 days. So we need to get back to the basics and talk to the patient and talk to each other. And I think that's the way to figure out these very complex medical problems.
I think that's the only way to figure out. It comes down to communication. And really, with that multidisciplinary approach, having doctors talk to each other, having the patients be able to communicate openly with us, and understanding that as a team, we have to do it together and keep the purity of medicine there.
The team is everything. I absolutely agree. We have to be able to think out of the box. Suzanne, the younger the patient, the more we want to unify everything into one hypothesis, into one diagnosis. But as the patient gets older, in 60s and 70s and 80s, well, now she's more likely, or he's more likely to have multiple things going wrong. So then you have to think of maybe it's not explained by one condition. Maybe there's 2 or 3 conditions. And it can become very difficult at times, but one has to think out of the box, be imaginative, be focused, and get as much information as possible.
This is such an interesting part of medicine that we don't always talk about. So thank you for your insight, and thank you so much for being here.
Thank you for having me.